More hypersensitivity. Yesterday we covered type 1 and type 4. Today I'm going to talk further about type 2 and type 3. Type 1, just as a reminder, according to Coombs and Gell classification, IgE antibody mediated hypersensitivity, and then that results in mast cells degranulation. Type 4 is cell-mediated response. It's a delayed response, takes 48 to 72 hours, while type 2 and type 3, they are antibody-mediated responses. Which antibodies? IgG and IgM. Now, there are certain, important differences. So if you look at the type 2 hypersensitivity, it's mainly about toxicity. It's destroying the cells, the target cells. So in the first case, you can see the natural killer K cells. They are targeting the cells with the help of antibody, while in the second case, the complement lysis is causing destruction to the target cells. While in case of immune complexes, the complement will be activated, but it's actually the antigen-antibody complex deposition that trigger the response. So first thing is, you can see there are a lot of similarities between these two types of responses. So these are about the features that are common and uncommon. So first thing is, both responses, type 2 and type 3, IgM and IgG mediated. Then I'll just ask you to first look at the effector cells. So in both the cases, phagocytic cells, macrophages, neutrophils and natural killer cells. Complement activation is involved, yes, and it takes 6 to 24 hours for both of them. But the thing that is not common between the two, so if you look at the A is about type 2 hypersensitivity. Target antigen, it binds to the target antigen. So it's always about the cell or the tissue. So whether it is cell or extracellular tissue, the antibodies will go and bind to it, and then it will cause damage or cytotoxicity. While in case of type 3, the antigens are soluble. They are anywhere in the bloodstream. Antibody, why those antigens are there circulating somewhere? What is the source of those antigens? We don't know. Sometimes autoimmune diseases, sometimes bacterial antigens, viral antigens, but in any case they are soluble and circulating in different places. Then when the antibodies bind to them, they make immune complexes. Those immune complexes then go at different places. Why they are deposited in kidney, in joints, we will see that. But this something which you have to understand is type 2 is more specific, tissue specific. So it will go to the tissue, the antibodies will go to the tissue and bind with the antigen, or it will bind with the surface of the cell. While in case of type 3, the antigens are circulating, antibodies are circulating, anywhere they can bind each other, make precipitates, and then those immune complexes are deposited at different places. So that's the main difference between type 2 and type 3. Now we'll talk more about the cytotoxic part of type 2 hypersensitivity. So it has more toxicity, it has more damage to the cell directly. What are those different methods of damage? So one is, of course, complement-mediated lysis. One is ADCC, antibody-dependent cell-mediated cytotoxicity. And the third one is phagocytosis. So the target cells, it will have the complement or the antibodies around it. It will be engulfed by the phagocytic cells. In any of these three cases, there will be damage to the cell. So that's why they are called as cytotoxic hypersensitivity. And the antigen can be from within the body, like autoimmune diseases, and the antigen can come from outside. So hypersensitivity 2 has two main categories. One is cytotoxic part, and another one is change in function, abnormal function. So it will not always just cause damage, sometimes it can alter the function as well. So we'll first focus on the cytotoxic component, later we'll see how they alter the function of different target cells. Now this is just an animation of antibody-dependent mediated lysis. So complement C1 is activated along with its R and S. Classical pathway activated. The end result is MAC formation, and that will punch hole in the target cell. So whatever, the antigen is in whichever cell, is it a red blood cell, is it any other tissue cell, first thing is antibody, IgM antibody or IgG antibodies, they bind to the target cell, result in classical complement pathway activation, MAC formation will take place, and that will cause damage to the cell. Type B mechanism, it is antibody dependent cell mediated cytotoxicity. Antibody bind with the receptors on the target cell, natural killer cell come and bind through FC receptors, and they put in their perforins and granzymes. So this again is cytotoxicity, but it is mediated by natural killer cells, and a similar thing can be done by which other cells? Eosinophils. Macrophages normally engulf, they don't release their perforins and granzymes. CD8 cells, so natural killer cells, CD8 cells and eosinophils, they all are antibody dependent cell mediated cytotoxicity, while macrophages main job is phagocytosis. So the C thing, after this, the C mechanism is sometimes, so far we talked about the cells. So is it a red blood cells? In both the cases, IgM or IgG bind to it, activate complement, cause damage. In B, antibody binds to the red blood cells, call the natural killer cell or CD8 cell, as a result antibody cell mediated cytotoxicity. What will happen if the target antigen is outside the cell, extracellular? It's not in the cell, in fact it's outside in the extracellular matrix. So one example is Goodpasture syndrome, in which the kidney membrane is the target. Okay, so in this case what is happening? This line, this line is the membrane, and these purple dots, these are the antigens. So first thing what happens, antibody comes and bind to it, classical pathway is activated, as a result C3A, C4A, C5A anaphylatoxins are produced, as well as membrane attack complex is produced, and more macrophages and neutrophils are called in, and all together, so the MAC formation, the neutrophil coming in, the macrophages coming in, they will cause damage. And now you see the membrane here, this is damaged, so it has now disruption here, here and here and here. And who caused it? Three components. So the complement system itself, neutrophils and macrophages, they cause damage to the extracellular matrix. So whether it is damage to the cell or it is damage to the extracellular matrix, it will be a combination of complement cascade as well as the ADCC. And the last part is the opsonization and phagocytosis. Sometimes the target cell will have the antigen on its surface, antibody will bind to it, and in this case you see antibody is helping the macrophage, but not for releasing perforins and granzymes, in fact to take it up, phagocytose. That's why it is opsonization, which is tagging, and phagocytosis, taking it up by the macrophages. Now, one part is against the alloantigens. Now, what are alloantigens? Which are similar within the species. So, between the humans, my antigens will be different from you, and yours will be from all of your colleagues. So, for example, best example is ABO or RH incompatibility. So, the red blood cells have different antigens present on their surfaces. If there is a type 2 reaction against such antigens, that is called as alloimmune response. Okay, and we'll see some details after a few minutes. Another is autoimmune. So your complement system, your opsonization, phagocytosis or ADCC, when attacks your own body structures, self proteins, that is autoimmune. And there are then two categories. One is destructive. As I said, they will destroy. This is a cytotoxic kind of a immune response. So the target cell or extracellular matrix will be destroyed, or the function will be altered. So the functions of different tissues, we'll talk about two examples: myasthenia gravis, an autoimmune disease, and Graves' disease. We'll talk about these two in detail. So now first example of ABO incompatibility. So there is a donor A in green. They have given his blood group A to someone who has got blood group B. What will be the major difference between the two? Which antibodies, preformed antibodies, are present in blood group B? Anti-A. So you can see in the circle below, IgM is the preformed antibody which is against the A antigen. So the donor has got A antigen on his red blood cells. They will directly bind to it. So of course, whether there will be complement mediated lysis, IgM will trigger the classical pathway, or there will be phagocytosis. Macrophages will engulf it and will cause damage to the red blood cells. Now here, just remember, when we talk about the ABO incompatibility, we talk about IgM antibodies. True? Preformed antibodies are IgM. But when we talk about the Rh incompatibility, we talk about IgG. They cross the placenta, everyone knows that. Why is these two different?
IgM is for polysaccharide.
Yes.
And IgG is for protein.
So?
Rh is composed from protein, and
very good.
The surface of the blood cell is from polysaccharide.
Very good. So ABO antigens, they are all carbohydrate in nature. So against them, IgM antibodies preformed are produced, while the Rh is a protein antigen. It will need always class switching, which is T dependent. So once the T cells help B cells, they will class switch, produce IgG, and IgG will cross the placenta and cause the Rh incompatibility. One more thing, whenever you are talking about IgM and IgG, just remember the size of the IgM is bigger. It will always stay in the blood vessel. It cannot squeeze out of the blood vessel. So whatever, mostly the intravascular lysis of the red blood cells that take place is because of IgM. And then the IgG, they are smaller, they can go out of the blood vessels into the extracellular matrix, they can cross placenta, they will already act as an opsonin. So when these cells go into the spleen, the extracellular lysis will take place as a result of IgG antibodies. So just link it simply: intravascular hemolysis IgM, extravascular hemolysis IgG. Now, in case of ABO incompatibility, if there is a reaction, what are the things that will happen? First, we'll start with A, the allergic signs. The patient will start to have itching or discomfort. He will have flushing, and the anxiety will increase. Then gradually he will develop fever, and with fever, tachycardia, tachypnea, and chills. And gradually, when the hemolysis increase, what they have got hemoglobinuria, because inside the blood vessel, lot of blood vessel red cells are destroyed. They release heptoglobin, cannot take up enough of it, so it will go down the kidney as hemoglobinuria, and the patient have low back pain. What you should do, first thing is stop the transfusion. So whatever is happening, the patient start to have fever or scratching. That's why when you start blood transfusion, you have to sit by the patient, check his pulse, blood pressure, and ask him if he's feeling okay. So when there is any of these signs, immediately stop the blood transfusion and start him normal saline. Now, Rh incompatibility, you all know it very well, I suppose. What is the reason for Rh incompatibility? Mother is Rh negative or baby is Rh negative? Mother. So, what happens in the first pregnancy? So during the pregnancy, the antibodies will be produced? So first pregnancy, during the pregnancy, antibodies are produced or not? No. No group is right, because during the pregnancy, antibodies are not produced. It's at the time of the birth. Some of the cells will seep into the mother's circulation, and the antigen will be exposed to mother. And if you remember, I told you one rule of hypersensitivity is, first time it is the sensitization. So the first time nothing happens. Same whether it is type 1, type 4, type 2, type 3. The first thing is sensitization. Those antigens go in and they will show the antigen to the mother immune response. Immunoglobulins will be produced. Which type of immunoglobulin? IgG. Then in the second pregnancy, now these antibodies can cross or not cross the placenta. So this response occur during the pregnancy or at the time of birth? During the pregnancy. So first is at the end of pregnancy when the baby is delivered, that time the exposure take place, and later after the birth mother is going to produce antibodies. Then in the second pregnancy IgGs are already present, they will seep in and cause response or damage. How they will cause, as we have already seen, either it can be complement mediated lysis and ADCC. They both can result in phagocytosis. All the three that we showed, the toxic mechanisms, any of these can cause damage. And this is how the erythroblastosis fetalis baby look like. Now we have already answered this question, that why ABO have got just transfusion reaction, not the the incompatibility, because mother will always have different blood. Most of the times there is a possibility that mother has different blood group than the baby, but still you don't hear about ABO incompatibility in mother and child. The reason is because IgM antibodies are produced in ABO antigens and it cannot cross the placenta. And autoimmune hemolytic anemias, what are these? There are again two types of antibodies produced. There are autoimmune diseases like SLE, rheumatoid arthritis, scleroderma. You will hear about all these autoimmune diseases. A lot of antibodies are produced. Sometimes IgM, sometimes IgG, depending on which type of antigen it is, whether a carbohydrate antigen or a protein antigen, and they will result in hemolysis. And what type of hemolysis take place? Of course, IgG will cause intra or extra? Extracellular hemolysis, and IgM will cause intracellular hemolysis. And this is the example of what is happening in the extracellular hemolysis. In the blood, IgG will bind to the red blood cells. These red blood cells, when go into the spleen, macrophages are there in the spleen. They will take up the complex that is formed on the surface of RBCs, and sometimes these RBCs are destroyed during this process, and sometimes they are engulfed as a whole. Now yesterday we talked about the molecular mimicry, that children less than 12 years of age, if they have got sore throat because of streptococcal infection, they tend to have heart disease. They actually, the same thing, same patients, they can have joint involvement, they can have skin involvement, and this particular condition is called as rheumatic fever. Okay, so the question is, do you think rheumatic fever is a type 2 hypersensitivity? What do you think? Is it type 2 or type 3?
Could be both, because it's in the extracellular. Not in the it's extracellular.
Okay, what is the main difference that I explained between type 2 and type 3 based on the antigen? Yes, so in type 3, antigen is circulating freely in the blood and antibodies are circulating freely. When they find each other, they will make precipitates and immune complexes are deposited. While in type 2, specific, so there is a cell, it has got antigen around it, that's number one condition, or the good posture syndrome situation that we saw, outside the cell but in the tissue the antigen is deposited, it's stuck there, antibody will come and bind to it. So we are talking about a specific tissue or a specific cell where either the antigen is around the cell or it is in the tissue. Antibody is later produced, it go and find and binds to it. Okay, so these are two different situations. Now in rheumatic fever, the streptococcal infection, it will have its own antigen, but this antigen will go and deposit in certain parts of the body, so they will act as extracellular component. So they bind to the tissue, the antigen itself, it is circulating but go and bind, or its structure is similar with the heart structure. So the antibodies think that the mitral valves, the valves of the heart, they are the bacteria. So in any case, you see it is going to the tissue. So is it type 2 or type 3? Type 2. So rheumatic fever is type 2. We will see here is sore throat because of hemolytic streptococci. That's the infection. Around 10 to 14 days later, the patient tend to have joint involvement, heart involvement, skin involvement, wherever the antigen go and deposit, or in case of heart, there is molecular mimicry, there is structure similarity between the antigen and your own body tissue. Now, whatever the case is, whether it considered it as the heart valves as antigen, or the antigen went and deposited, what is happening? Antibody again find the antigen, classical pathway is activated, same time C3a, C5a activated, they bring neutrophils, so it is complement cascade, it is the neutrophils that comes in, or sometimes the natural killer cell, they are not shown here. Any of these three mechanisms will damage the tissue itself or cells itself, so there will be destruction. Now so far we talked about the three mechanisms: complement mediated destruction, ADCC mediated or opsonization phagocytosis, then there is damage to the cells. Another part I told you is about the altered function. So sometimes the antibodies are produced, they will go to the tissue or the antigen where they will bind, but not to destroy it, but to change the function. And this is called as abnormal, they will create abnormal physiology, so pathology will be created because altering the function. Best example is Graves' disease. Have you heard of Graves' disease? So there is a thyroid gland in the neck. Its function is to produce thyroid hormones, T3 and T4. These hormones are controlled by pituitary gland in the brain, okay? So that gland controls the thyroid gland, and then the thyroid gland produces these hormones, and these hormones have several functions. So I'll just keep it simple. In Graves' disease, what happens? The thyroid hormone level is increased. So let's say in the brain there is a gland, at the base of the brain is a gland which is called as pituitary gland. This controls the thyroid gland. And then thyroid gland produces two hormones, T3 and T4. Okay, and they perform different functions, hormonal functions. When the pituitary releases a substance that controls its function, that is called as thyroid stimulating hormone. Okay, so what is happening? Pituitary gland is producing a hormone that is called as thyroid stimulating hormone. It comes to the thyroid gland, bind to the thyroid stimulating hormone receptor. Thyroid will release T3, T4 whenever it is needed. Okay, now in this disease, what is happening? The body will produce antibodies that will resemble thyroid stimulating hormone. So they will resemble this, and these antibodies will bind to these receptors. Now what is going on? A false signal is going to the gland that keep on producing T3 and T4. Normally, when your brain knows when your body needs thyroid hormone, okay? So let's say its level is reduced. This is signaled to the pituitary gland. Pituitary gland will produce these thyroid hormones, thyroid stimulating hormone. It will stimulate the thyroid to produce T3 and T4. But now in this condition, Graves' disease, your body is producing abnormal antibodies. All these antibodies resemble TSH, and they will bind to TSH receptor. Does it make sense to you? So when these antibodies bind, it's a false signal. Your body don't need T3 and T4, but this antibody just binds and tell the thyroid gland to keep producing hormone. So because of abnormal functioning, the thyroid gland size will increase. So you can see in the neck there is a bulging, huge size of the thyroid gland. And there is also, this T3 and T4 causes lot of effects. One of the effects is causes bulging of the eyes. So these are two typical features of the thyroid. So when thyroid hormone is increased, it is called as thyrotoxicosis. Okay, toxicity of thyroid hormone. And all this is happening, why? Because your body is producing abnormal antibodies against the TSH receptor. Is it clear? Everyone is okay with this? Now, so this was increasing the function. On the other hand, there is another condition that will reduce the function. So antibodies that are produced as autoimmune response, sometimes they can reduce the function as well. And what is that? So you know the structure of at the nerve, neuromuscular junction. So let's say this is the nerve, and it is attached to a muscle. So when a nerve impulse comes, at the neuromuscular junction, there are certain chemical mediators. In this figure, they are labeled as acetylcholine. Okay, these acetylcholine will be released, and when they are released, this acetylcholine binds to its receptor. So there is a receptor for it here. This is acetylcholine. Okay, it has a receptor on muscles. So when it is nerve impulse comes, this is released, it binds to its receptor, and then the muscle will cause contraction. Okay, so this is just a simplified version of neuromuscular junction physiology. Now in this disease, what is happening? Antibodies are produced that will block this receptor. This receptor will be blocked. So whenever a nerve impulse comes, it causes acetylcholine release. It will not be able to bind because it has already been blocked by the antibody. So as a result, you can see there are three figures. In the first figure, when the patient of myasthenia gravis, myas is for muscle, asthenia means lot of weakness, severe weakness. Gravis is grave, excess weakness. So this is a disease in which there is muscular weakness. And what is happening? In the morning, the patient eyes, he is able to open both eyes. Gradually, as the day passes, you can see in the mid of the day and then late night, the patient is not able to keep his eyes open. The eyelids, he cannot keep open. Why? Because of this. When the nerve impulse goes, acetylcholine released, normally it binds to the receptor, muscle can contract and it can perform its function. But in this disease, antibody has blocked the receptor, impulse is not going further, muscle is not told to contract. As a result, it will become flaccid, weak, and it will drop, eyelid dropping. So this is the situation of myasthenia gravis as a result of antibody against the receptor. So now we have discussed different situations. There is destruction of red blood cells, either ABO incompatibility or the ABO transfusion reaction, or RH incompatibility. Then in autoimmune conditions, there are intravascular hemolysis or extravascular hemolysis because of IgG or IgM. Then abnormal functions, whether Graves' disease or thyrotoxicosis, where the function was enhanced, an extra signal was given through the receptor, or the receptor was blocked. In case of myasthenia gravis, the receptor of acetylcholine is blocked. Acetylcholine will not bind and it will not perform the contraction of the muscles. So type 2 hypersensitivity, the main concept is same. Antigen is present on the cell or in the tissue, and antibody will go and bind. In some examples, it caused destruction. That's why it's mainly caused as cytotoxicity. On the other hand, it is altering the function, either blocking or enhancing. So these are some clinical examples of type 2 hypersensitivity. Now, if there is hypersensitivity, can you measure it? Can you test it in the laboratories? So you might have heard of these tests: direct Coombs test, indirect Coombs test, and then there is fluorescent antibody staining of the biopsy tissue. So we'll keep these two tests, directly focus on RH incompatibility. You know about it. It will make more sense now. Have you heard of these two? Yes? No? Okay. So if there is a baby, he's supposedly having Rh positive, mother is Rh negative, and at the time of the birth you suspect that possibly the antigens